Hi, my name is Rebecca and I'm a graduate teaching assistant at the University of Kentucky in the Department of Kinesiology and Health Promotion. In this lab, you will learn how to perform a maximal graded exercise tolerance test using a metabolic cart, as well as how to assess an individual's heart function through electrocardiogram, or more commonly known as an ECG. A graded exercise tolerance test is the most widely used assessment to examine dynamic relationships between exercise and integrated physiological systems and is useful for diagnosing clinical coronary heart disease. The information gained from the GXT can be applied to clinical diagnostics, research, screenings, sports performance, and occupational safety. Selected cardiovascular, pulmonary, and metabolic variables are collected during the test to evaluate exercise tolerance and represents the efficiency in which the body can consume, deliver, and utilize oxygen. During this test, exercise physiologists use specialized instruments to measure these variables. One instrument is called the metabolic cart, and it is used to measure the concentration of inspired and expired gases during exercise. During a maximal graded exercise tolerance test, an ECG will also be performed to collect data on the heart function during the stress of exercise. Research has shown that integrated analysis of exercise tolerance tests are strong predictors for long-term cardiovascular mortality and is useful in both men and women. Learning how to perform the GXT with the ECG will give you a broader understanding of cardiovascular physiological parameters occurring during maximal graded exercise tests. Therefore, the purpose of this lab is to become familiar with the procedures and analysis of administering a graded exercise tolerance test, maximal exercise with an ECG. GXTs are used by exercise physiologists, cardiologists, and cardiac rehab specialists to examine the function of the heart before, after, and during exercise, or possibly a post-operative procedure. While the individual is exercising, the GXT is providing us with a measure of cardiorespiratory fitness by measuring the individual's maximal oxygen consumption, or VO2 max, which is the maximal volume of oxygen that an individual can consume, distribute, and utilize. We are also provided with an indirect measurement of energy expenditure, or ATP production. Specifically, this test measures the amount of oxygen consumed and carbon dioxide produced. The participant will breathe in room air, mixture of oxygen, nitrogen, and carbon dioxide through the tube. Then the expired air will be carried to the gas analyzer attached to the metabolic cart. Then the expired air is compared to the known concentration of the room air to calculate the volume of oxygen that is being consumed versus the amount of carbon dioxide that is being produced during exercise. One final measurement we get from the GXT is the respiratory exchange ratio, or RER. This is a ratio between the amount of carbon dioxide produced and oxygen consumed. This value can be used to estimate the fuel source, carbohydrate or fat, used during exercise. Theoretically, a value of 0.7 is associated with 100% fat use. A value of 0.86 is associated with a combination of fat, 47%, and carbohydrates, 53%, and a value of 1.0 or above is associated with 100% carbohydrate use. Importantly, the RER can only be used to estimate the fuel source while the subject is in a steady state. The RER during the final minute of the maximal GXT can also provide information to determine if peak VO2 max has been achieved. In this lab, we are specifically concerned with understanding the basics of the GXT and reviewing the ECG principles from ECG Lab 1 and building upon those. If we refer back to the ECG Part 1 lab video, remember the ECG is a non-invasive measurement of the electrical activity of the heart. The ECG will be used today as a modified 12-lead ECG. If you recall from ECG Lab 1, we have 4 limb electrodes and 6 chest electrodes. By using the 10 electrodes strategically placed on the chest, we can view the heart in 12 different ways. The limb leads give us 6 different views of the heart in a frontal plane, whereas the 6 chest leads give us 6 views of the heart in the transverse plane. The tracings from each lead tell us the direction of the electrical activity occurring in the myocytes when depolarization, plateau, and repolarization occur. Also, as resting membrane potential of the action potentials occur. Following depolarization, the heart must repolarize to get ready for the next cardiac cycle, which also shows on the ECG. The different leads are important for analyzing and interpreting heart function, and the ECG tracings are also used to determine heart rate, mean electrical axis, and cardiac arrhythmias before, during, and after the GXT. Heart rate is determined by the distance between the R peaks, or the distance of the R to R interval. The mean electrical axis tells the interpreter the net direction of the heart's depolarization. The mean electrical axis can be calculated by locating the QRS complex in lead 1 and AVF. A cardiac arrhythmia is an irregular heart rhythm at rest. Normal sinus rhythm is considered to be a resting heart rate of 60 to 100 beats per minute. Sinus bradycardia is determined when the resting heart rate is below 60 beats per minute, and sinus tachycardia is determined when the resting heart rate is above 100 beats per minute. An ECG may be coupled with a maximal exercise test to evaluate clinical health measurements if determined necessary by the exercise physiologist or the clinic's physician. This is also termed a graded exercise tolerance test, or GXT. However, if a client or patient is referred to the exercise physiologist for an ECG, it is important to first have knowledge of the clinical significance associated with the normal and abnormal ECG changes is important for the registered exercise physiologist. This can include ECG changes associated with exercise, drug therapy, electrocyte abnormalities, or myocardial injury or infarction. Second, it's important to get a record of the current medications since there are several medications that impact electrical activity of the heart and heart rate. Last, you always want to record a resting ECG prior to the performance of a GXT to determine if there are any present abnormalities that the participant is unaware of. This will help us to determine if it's safe to continue with the GXT. The difference between a resting ECG and the exercise ECG is that the heart is put under an added stress. This allows us to evaluate heart function and any changes that occur when stress is added. For this lab experiment, we will review proper preparation and setup for the ECG recordings, measure an individual's maximal oxygen consumption, or VO2 max, and determine the heart rate and mean electrical axis changes that may occur during the maximal graded exercise test, along with any cardiac abnormalities that might appear. We will be using a cycle ergometer protocol that increases resistance while pedal cadence stays constant. First, the participant is hooked up to the metabolic cart where he or she is breathing through a one-way valve that will allow for the measurement of oxygen consumption and carbon dioxide production throughout the test. Second, the ECG machine will measure the electrical activity of the heart. First, we want to prep the individual for the ECG and get a resting ECG recording. Remember, a more in-depth overview of the GXT specifically and the measurements obtained during it and how the metabolic cart works specifically was given to you in your 420 class. Please refer back to that video if needed. For skin preparation, we want to remove any hair, dirt, or dead skin and clean with alcohol pad. Make sure the surface is dry before attaching the electrodes. Remember, we're setting up for a modified ECG. The right arm and left arm are placed below the midpoint of the clavicle on the correct side. The right leg and left leg are in line with each arm electrode on the torso just below the final rib of the correct side. Remember, these 4 electrodes make up 6 leads. Lead 1, lead 2, lead 3, AVF, AVR, and AVL. Next, we will place the chest electrodes. Remember from the previous lab, we first locate the participant's sternal notch and slide your index finger to the right or left past the sternum, then bringing the finger down until you feel the soft tissue space. This is the intercostal space. Remember, V1 and V2 are placed in the 4th intercostal space, with V1 to the right of the sternum and V2 to the left of the sternum. V4, 5, and 6 are placed in the fifth intercostal space, with V3 directly dividing the distance between V2 and V4. Prior to the test, we will take the participants' resting blood pressure and resting ECG to ensure they are healthy and ready to begin the warm-up. The subject will complete a 3-minute warm-up at a self-selected pace with no resistance. During this time, it is important to monitor the ECG recording to make sure the signal is clear. Following the warm-up, the participant will wear a nose clip and breathe through the one-way valve. This ensures everything they breathe in is going straight into the metabolic cart for analysis. As we begin the test, we will start the test at a resistance of 1 to 1.5 kilograms or 420 to 630 kilograms per meter per minute, or 69 to 100 watts. The power output will increase by 0.5 kilogram, approximately 30 watts, every 2 minutes until voluntary exhaustion or the subject's pedal rate falls below 70 revolutions per minute for more than 10 seconds, despite strong verbal encouragement. At the end of each 2-minute stage, we will print the ECG tracing for the completed stage. In addition, the participant's heart rate, RAR, and blood pressure will be recorded, and we will ask the participant their rate of perceived exertion, or RPE, on a Borg scale 6 to 20. Once the test is completed, remove the one-way valve and have the subject continue to pedal at a slow pace with no resistance until they feel somewhat recovered. The maximal exercise test should take approximately 8 to 12 minutes. It is important to have someone continually evaluating the ECG recording for any changes. If certain ECG abnormalities are observed, this would be cause to terminate the exercise test immediately. Now for the application part of the lab. First, let's take a look at the ECG recording from the test. Using these tracings, we can determine heart rate and mean electrical axis during each stage of the test. The mean electrical axis tells the interpreter the net direction of the heart's depolarization, which can indicate the position of the heart in the chest, or if necrosis of the muscle is causing a shift in the net direction of the electrical activity. The mean electrical axis can be calculated by locating the QRS complex in lead 1 and AVF. First, determine the baseline of the ST segment with a ruler and draw a horizontal line. Then, sum up the height of the Q wave, the height of the R wave, and the height of the S wave in millimeters according to their relationship with the ST segment baseline. Then extrapolate the vector of the intersected lines on the graph, using the hexaaxial reference system to determine if the mean electrical axis is normal, 0 to 90 degrees, has right axis deviation, 90 to 180 degrees, extreme right axis deviation, 180 to negative 90 degrees, or left axis deviation, negative 90 to 0 degrees. Right axis deviation is common in tall, slender people, also called vertical displacement of the QRS vector. And horizontal displacement, or left axis deviation, is common in those with obesity. Now, for heart rate, in ECG Lab 1, we talked about the various components of the ECG cycle. During a single cardiac cycle, the tracings consist of a P wave, PR interval, PR segment, QRS complex, ST segment, T wave, and QT interval. We also learned how to determine heart rate based on the distance between the R to R interval. Remember, there's 2 cardiac cycles, and we use the box method to determine heart rate. In summary, the purpose of this lab was to become familiar with the procedures and measurements used to establish an individual's VO2 max and interpret the physiological changes of the heart's electrical activity during a graded exercise tolerance test. Specifically, this test gives clinicians and practitioners an estimate for individuals' level of cardiorespiratory fitness and allows them to examine heart function under stress. For your lab report, your TA will provide you data from a hypothetical participant that completed the same laboratory experiment performed in this video. As always, please ask your TA if you have any questions, and thank you for watching.